السلام عليكم ورحمة الله.
وعليكم السلام brother.
How are you? I hope all of you are healthy. All of you, alhamdulillah, are okay?
Okay, doctor.
Alhamdulillah. Inshallah, Allah protect you, inshallah, and be ready to see you soon, inshallah. Today we are going to speak about the NRP. I don't know, before we used to teach your student about the 7th editions. Now we got new edition. And this is an important point for all of us about what is going with medicine. Okay, so let us start by Al-Kitab before we start to discuss this important issue. Bismillah ar-Rahman ar-Rahim, alhamdulillah rabbil alamin. As I need, inshallah, to alarm you as a new staff coming soon to join us in the clinical work, we must take care that the medicine is an evolving. Sometimes you are practicing many things and you found yourself need to change it because there is now evidence-based. Evidence-based has many levels, you must know it. At the top, there is multiple randomized control study. And maybe the one at the end is a consultant experience, which you also consider, but it is not the top one like before, okay? So it is very important to do something, to know what is evidence in the medicine. Number two, you must be able to open your mind for changes and thinking about it and thinking about researches, which will guide you for that. Also, an important decision, don't rely on the old edition of books. You see this NRP book is coming every 5 years, and you will find a lot of changes. Okay? This NRP is divided according to the needs of the baby. Try to be patient because we are not face-to-face, but it is very important. I mean, the most important thing in neonate is anticipate and preparing for resuscitation. Okay? Number two, if any baby is delivered, we must evaluate and go for something known as initial steps, which must take about 30 seconds. Okay? As I write here, about 85 of the babies will cry automatically, plus 10%, so it is about 95 will cry with the initial steps, which you are very happy. Because if the baby cry, we are laughing. And if he not cry, we may be the one we need to be very cautious, okay? About 5% of the babies need positive pressure ventilation. The best example for that is the ambu bagging or TB, okay? Still about 2 baby, even of the full term, may need endotracheal intubation. And about 0.2% still need medication, which is the most common 2 drugs is the epinephrine and the normal saline. Okay? The book is like that, but this is the most important point. And this one, you need to print it, every one of you. If you need, I can send you, inshallah, the lecture. You need to print the flow charts. Which if you understand this one, So it is very, very, inshallah, enough for you. The green one is the previous one. So now this is the updating, okay? Are you hearing me nicely?
Yes, doctor.
Be ready. I may need to ask you some question to feel that I am not speaking alone, okay? For any delivery, inshallah, hoping to see you now with us in the branch of neonate, which is a very promising. Now we can resuscitate 400 or 500 gram, and they can grow with a good percentages, with less mortality and morbidity. You can treat many cases like breast asphyxia, which is very promising. If you put any phone from the labor ward that you have, you are going like for emergency CS, you must ask for questions. Okay, so the first step, if you got any message from labor ward, you need to ask 4 questions. The first one is how many, the first one is the baby is term or preterm. Okay, second one, is the baby clear amniotic fluid or it is meconium or blood stained amniotic fluid. Okay. The third one, is there any other risk factor? And the fourth one, what is our plan for the cord? I mean, we are going to clamp the cord directly, or we will wait for delayed cord clamping for about 30 to 60 seconds. Okay, so we must be planned. And after that, you need to assign your team, especially there is a critical patient or premature, either term but sick, or preterm, you assigned your team. You must work as a team. Whatever you are strong, you cannot save the neonate alone. You need help for that. So you will assign your team and try to give them the knowledge that this baby is a preterm. We suspect he have respiratory distress syndrome, so we need to resuscitate him and then intubate and give him like that. And at that moment, you must assign the team. I mean, you must say who is the team leader, and then who will be the one who will care for the respiratory, which we call him the ventilating one, who will go for the chest compression if the baby needs chest compression, and the third one who will give medication, and even the fourth one can be who is the one who will make documentation. Okay, and you will go directly to prepare the equipments. We'll speak about that. So this is a very important 3 points. Okay, number 1, ask for questions. Number 2, your team, and do briefing and delegate the work. And the number 3 is the equipment check. Of course, if you have time or one of your staff are able to communicate with the family, this is the top, to tell them that is the issue which is running, you are doing that, and we just counseling you about the result, okay? So all this job, better to be ready before delivery of the baby. After delivery of the baby, you will ask yourself 3 questions. It looks term or preterm? How is the tone of the baby? I mean, the tone is flexed and crying and like that, or is a very relaxed, okay, and like floppy one, okay? And the third one, he is breathing or crying. Crying, of course, is the top activity of the breathing, okay? So remember that we ask ourselves about 3 questions: tone, term, tone, and crying. TTC. I used it to write it to TTC just to remember you are in the East Coast area. Okay. After that, you will ask yourself, if all these 3 are yes, I mean, if he is a term and with good tone and crying or breathing, I will prepare to stay with the mother, I will do the initial step as needed with routine care. But I must also do evaluation for the baby because some baby may deteriorate also after that. If anyone, one enough, only one, if the baby preterm, if has not good tone, he is not crying or breathing, so I must put the baby directly and put him in a warmer. When you come to the nursery, you will find this warmer, which is a resuscitator with warmer up. Why warmer? Because we have two things which are threatening the baby and they make a bad prognosis, which is number one is the hypoglycemia, number two is the hyponatremia, is the hypoglycemia and hypothermia. Okay, I will put the baby in the warmer. I will do dry, but we will speak about dry because for preterm we are not doing dry. Preterm less than 32 weeker, even 31 plus 6 days, we will put him in a plastic bag. Just cover him in a plastic bag from the neck until the toes. We can make one limb out if we need to use it, and also if we need to insert UVC, UEC, we will make a small hole near the umbilicus, because this is the best thing to protect him from hypothermia. Okay, so you have now put the baby on a warmer, dry the baby if not preterm, and stimulate. How to stimulate also, we will speak about that. And make that position of the airway, which is the best, is the sniffing position, which help the baby to breathe smoothly. And now suction, if baby needs, I mean, he has secretions or has abnormal respiration or like that. We did the initial signs as we speak before. About 80% will cry immediately and go to the mother. Another 10% can be after doing our initial steps, will also cry. Okay. We'll ask ourselves, has any apnea or gasping or heart rate less than 100? Another 3 questions now. We said here TTC. Here now we are speaking about the heart rate and the respiratory effort. And if the baby is a preterm or like that, we can include also the pulse oximeter. But here, what I wrote, apnea or gasping. Anyone knows what is gasping?
Shallow breathing like that?
Yes, gasping, the one breath which we got last breath for us. It is like the end of breath. Okay, this is not calculated as a breath. It is calculated as apnea in neonates. Okay, so it is very important not to be not to consider any gasping as a breathing. Apnea is equal to gasping, or gasping equal to apnea. Okay, it is very important. Don't be deceived by that. So if the patient has apnea or the heart rate is less than 100, why? Because the heart rate of the newborn is from 120 to 160 or 80. If no, okay, or yes, we will take decision. If no, I mean the heart rate, the patient is breathing and the heart rate is more than 100 or 100 and more, I will see if the patient has labored breathing, I mean has recession or persistent cyanosis, okay? We will know from this table below how much is the target oxygen saturation. If yes, we need to make position of the airway and make pulse oximeter and give oxygen if needed. But for this situation, this baby may need CPAP. What is CPAP? This is a type of positive pressure ventilation known as continuous positive airway pressure. It will give also only like beep only, okay? But if the baby has apnea or gasping or heart rate less than 100, whatever, you must go for the BPV, positive pressure ventilation, okay? We are using now, we are putting also pulse oximeter, and you must know that pulse oximeter can be put it in any limb, but the only consider one periductal is the right arm. So the right arm is periductal, the other may consider as a postductal. So it is better to be put in the right arm. Okay. Pulse oximeter, consider cardiac monitoring at that point. And then after 30 seconds of positive pressure ventilation, we are going to ask ourselves again about the respiration, about the heart rate, and about the pulse oximeter, because we put now the pulse oximeter, and these three questions will working with us. Am I clear? So I will ask, how is the heart rate? Still low? Yes. So I will make sure that the baby has a good respiration or not. My BBV is accurate, and there is some correction steps known as Mr. Soba will speak about. So consider intubation or laryngeal mask with cardiac. At this point, it means that the baby needs to be intubated, okay? And then after intubation, we will give 30-second respiration and check the heart rate. If the heart rate is still dropping less than 60, so you must know two numbers, the number 60 and the number 100. Okay, if said yes, so if not intubated, he must intubate it at that point, and we must start chest compression. But chest compression coordinated with the positive pressure ventilation, and now we are going to increase the oxygen to 100%. And prepare by inserting emergency line, which is UVC. Okay, the UVC is considered the central line, alhamdulillah, from Allah. This umbilical cord have 3 vessels, 1 UVC and 2 UAC. Okay, so if you insert cannula in each of this, 1 artery, 1 vein, so you have a central venous and the central arterial line, non-UVC, UAC. So now if the baby heart rate is still than 100, we must continue respiratory support by intubation. If the heart rate came less than 60, we must start, okay, chest compression. If still less than 60, we are going to consider medication. The most important 2 medication for us is the epinephrine and the fluids. The most important table inside this chart, which you need everyone to print it and study it, please, for our coming clinical session. You must know that the baby in the first minute of life, we suspected his oxygen saturation to be 60 to 65. We are not suspected all babies to be 100. Yes, many babies can go welcome, but we are not giving oxygen if the saturation is more than 65. 2 minutes 70, 3 minutes 75, 4 minutes 80. 5 minutes, we can accept to come from 80 to 85 is the normal acceptable oxygen saturation. For 10 minutes, we accepted from 85 to 95. So don't hurry and give oxygen for any baby, whatever you saw him. That's why we wrote here. If 35 gestation and above, we use the oxygen through the oxygen blender on 21. If more of less than that, we can use from 21 to 30, maximum 40, because some doctors used it to open it to make it 100%. And as you know, which I used it to tell your colleagues before, the first drug we are using for any resuscitation is what is the first drug we use for resuscitation? Anyone knows?
Epinephrine, doctor.
Any other answer? Epinephrine, of course, it is a gold standard for resuscitation. But I'm asking about the first drug. The first drug is the oxygen. Okay? The first drug is the oxygen, and the oxygen considered as a drug, and you must be dosage adjusted. If the patient need 21, don't give him 30. If the patient need 30, don't give him 100, like that. Okay, so this table guide us if you need to keep the life. And don't forget the ayah which I put in the first slide, that وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. If you need to help this baby to life, and I mean by the life, not to continue life while he is cerebral palsy, I mean to continue life while he is in the best of health and the brain. Okay, we have 3 minutes. What do we have? 3 minutes. Okay, the first minute is just to ask yourself about the baby. It means assessment by TTC, and do the initial steps. If okay, go to the mother. If not okay, after initial steps, there is no, you must go for ambu bagging or positive pressure ventilation. All this must be done within 1 minute. The second minute, if not responds to the BBV, you must go for intubation, okay? And if the heart rate is low, you must go for chest compression. Ideally, it is better to be within the extra 2 minutes to be intubated, to do chest compression, and to give medication like normal epinephrine or normal saline. Why you are very tight in time? Yes, because after that, the brain will be affected by the hypoxia. Just a while. Hello. Alaikum salam. Yes. Yes. No, it will be 11:15. Can be. He is going to finish. You need me to come now or come after at 11:15? He has no more patients? Okay. Just give me 5 minutes, I will come to you. Okay, bye. So sorry, I need to leave after 5 minutes. It is a good chance for you to study the table. So the first minute is the assessment, okay, initial step and the BBV. The second minute is the intubation and chest compression. The third minute, for including with that one, is the epinephrine, and the target oxygen must be followed, please. Okay, if you did that, the brain will be saved. If you didn't do that, the baby may survive, but he will get what is known as multi-organ affection or multi-organ failure, which are very, very dangerous. Okay. Then we have these 4 questions which we speak. I will revise it for you. Okay. How to do rapid evaluation by the TTC. Okay. What is the important to work as a team? The baby may be very small, which is 500, but he need maybe up to 5 persons to save him. Okay. I will send the lecture to you, inshallah. Okay. And give me, I don't know how much it will take this job, but sure, I will finish and come to you, inshallah. Okay. Sorry for that. Do you have any teaching after that?
No.
Good. So this will give me a good opportunity to continue with you. Now I will try to send it to your colleague. The slide, do you have it? I think this slide is the new one. The one which may be available with you is the old one, which is not working. I will drop it to you for a while just to study this one. Bismillah. I used to send it, but I forgot today to drop it to you, the lecture. Now, can you share this one with the group, please, until I come to you? Okay.
Okay.
Also, we need to discuss about the clinical teaching after that, how we are going to do. Bismillah. السلام عليكم. السلام عليكم.
Waalaikumsalam. Salam.
You are going to share the slide, or should I do? Okay, share screen. Bismillah ar-Rahman ar-Rahim. So we got now an important point about something known as the golden minutes. Okay. What is the golden minutes for the newborn? Is the first 3 minutes, maximum 5 minutes, which is able to save two things: save the life and save the organs, especially the brain. So the area of resuscitating preterm must consider that. Okay. So again, what we are doing, if we got any phone to your unit from the ONG, from obstetric, you must ask 4 questions. Number 1, what is the expected gestational age? I will confirm it after that, because sometimes even some ladies are unbooked. We just measure by hand like that. It is not 100% correct. So we must ask about the gestational age. Is a term, preterm, how many weeks, like that. Number 2, if the amniotic fluid is clear, I mean, is it meconium stained, blood stained, like that. Number 3, is there any risk, any additional risk factor, which are very important. Number 4, what is our umbilical cord management? Umbilical cord management are very important to be known to us. Okay, we'll speak about that, the new era of delayed cord clamping, which are very important. Okay, remember that some newborn, even full term, without any risk factor, they may require resuscitation. And sometimes this is a more burden to the doctor, because if you know you have preterm, you have meconium, you are very prepared by just to call you, doctor, baby without any risk factor didn't cry, so you must rush, otherwise the result will not be good. The other thing, now our recommendation, every birth should be attended by at least one qualified individual, whose only responsibility is the management of the newly born baby. She is not engaged. She is not helping obstetric. No, only that. So we must have like midwife is there, or our staff nurse in the labor ward. But if there is any risk factor, so it must be at least 2 qualified persons. Okay, qualified team is for resuscitation if identified more risk factor like preterm, like that. Okay, we must check our equipments. Okay, equipments must be checked before. So number 1, we're asking for questions. We are asking the labor obstetric team about this one, gestational age, okay, amniotic fluid clear or not, any additional risk factor, and what about the umbilical cord care. We are trying to prepare our equipment, okay, our equipments, and then briefing our team as we speak before. After delivery, we are doing rapid evaluation. As I told you, it is by our TC, okay? So if the patient is a good, if we answer as we said before, if the patient is good, we can remain with the mother. If not good, anyone, no, if you said the baby is stable, the baby has good tone and crying, okay, go to the mother. Anyone, so we must go for radiant warmer for further intervention. What is this further? Airway, we did initial step for it. We will speak about the initial steps. Breathing, this is the second step. We are doing positive pressure ventilation. Okay. Circulation, if severe bradycardia persistent in spite of assisted ventilation, we are going to do intubation and chest compression. Okay. And then if the patient not yet improved, we are going to consider drug. If still bradycardia in spite of ventilation, chest compression, and like that. Okay. Is it enough? Yes, but the result will not come until we have working as a team. That's why the teamwork and good communication, even remember that, please, every one of you must remember that, even though each individual alone may have a good knowledge and skill to perform the successful resuscitation, but effective team communication is a vital one. And the bad prognosis and the death of most of the newborn come because of there is poor teamwork communication. The teamwork is not communicated together. Okay, of course, one of these challenges is the time factor. As I told you, you need to finish everything around 3 minutes. If you are alone with short of team or uncooperative team, you cannot finish this one. Number 2, the sequence. You are very busy and under stress. You have sequence as we speak before. We have A, B, C, D, like that. And beside that, we have communication. Must be communication team with us to alert us about the timing, okay? So number one, we must work as a team, okay? We must follow time factor, we must follow the sequence, and we must remove any confusion in efficiency which may occur. So our job will be, inshallah, on the top for saving the future of our kids. They are now speaking about a closed team, and it is very important, a closed loop for the team leader. If we need to work as a team, okay, so it must be a leader. We cannot work without leader. Everyone consider himself as a leader is not a good to achieve anything. So the team leader even can be nurse, can be doctor, can be even physiotherapist from our unit, because physiotherapist is a cornerstone in our unit for caring of the respiratory for intubated baby. Okay, so any team can work as a leader. There must be a good communication skills. I mean, it must be clear, directed to the special individual, please, blah, blah, we'll do this one. We must share information. We must delegate the responsibility and ensure coordination. Okay. Also, we need to continue professional environment. I mean, don't be chaotic situation. Even if some mistake is done, you try to rapidly correct, and then don't go through why this happened now. There will be briefing after that. So you must be very professional in giving the order, in correcting mistakes like that. You must use your resources, okay? And you must be aware from the situation, the entire clinical situation. If the leader, it is very important even for the leader of the team, if he is involved with in a procedure, like he is going to insert, to intubate, insert UVC like that, it is better for someone else who will take the leadership, okay? And this leadership has its own responsibility, which is known as closed loop. Don't make it open, okay? Number one, all the team are sharing their responsibility, okay? And share also their information. The closed loop, you must give instruction, are heard and understood. So the instruction must be clear. And it is directed to specific individual. I mean, Dr. Hamza is going to do that, and they must call your team by name. This is ideal, okay? And there must be eye-to-eye contact, and you must speak clearly. After giving instruction, ask the receiver to report back. I mean, Dr. Fulan, intubate this baby. Okay, then once he did, okay, already intubated and the ET tube is in. After receiving instruction, repeat the instruction back to the center. This is another important one, sometimes especially for medication and some critical medication like epinephrine. If you are going, please give 0.2 ml per kilo of epinephrine 1/10,000 rapidly infusion, and then give bolus 3 ml of normal saline. So I give this instruction to Dr. M. So Dr. M must, okay, repeat the instruction. Now I am going to give adrenaline, blah, 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 blah. So if there is any confusion or any wrong understanding, it will not give. Otherwise, you can give the medication and they say, oh, by mistake. I understood, I hear, I like that, okay? Of course, documentation are very important. Even for medical legal issue, even for improving our achievements, okay? And this is the NRB 10 behavioral skills. And really, I need you to take this for your life. It is very important for every medical practice and even for your working whatever. You must know your environment. You must anticipate and plan. You must assume leadership role. You must communicate effectively. You must delegate the work and allocate attention wisely to everyone. use all available information, use available resources, call for help when needed, don't be late. For neonatal, don't be ashamed to call for help and maintain professional behavior. If you put these key behavioral skills in your life to be a second nature for you, I think it is a very, 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 very nice one, even from Islamic concepts. And here is just examples how to every behavioral can be applied. You can go through it, okay? And now, as I told you, the baby now delivered, and I asked it just before delivery, sorry, we make antenatal screening, I mean for the family, and we ask the OMG for question, what is the gestational age? Is it clear amniotic fluid? Is there any additional risk factor? What is the umbilical cord management plans? They told you we already planned for 60 seconds delayed cord clamp. Okay, so you make your team briefing and then equipment check, and remember always we must work like a team. Even for this musical team, they are the one who can everyone cheer, but there must be no odd behavior. Okay, for the equipment, it depends according to our procedure. We speak before that we have initial step, we have positive pressure ventilation, and if needed, we have chest compression. If needed, we have medication. So the equipment is arranged at the same one. I mean, every baby need resuscitation must put in warmer. For the initial step, we must make clear airway. So I need to put the equipment is for clear airway, either just simple bulb, or I am going to put suctioning through electric one, okay? Auscultation, which is the stethoscope, must be available. Otherwise, two important things, the equipment must be ready and working. If you have a stethoscope which has not functioning, there is no cone like that, it is useless. Now, if I need to ventilate, so which mask I am using, how is the oxygen connection? If I need to intubate, it is a very, very important how to intubate, what is the medication? So I have two medication which are used commonly, which is the epinephrine and normal saline. The thermoregulation must be continued on all baby needs resuscitation and others, okay? Others, like I need to prepare surfactant for this baby, this child has some other problem, I must be ready for it. So it is very, very important, please, this equipment. And here again, this is a long table for a warmer, what must be there to clear the airway, what I need to auscultate, I need a stethoscope. For ventilation, I need all this list for oxygenation, for intubation, for medication. So it is very, very clear to us. And this equipment need to be adjusted and prepared in 2 minutes. Hopefully in the hospital it is already ready, but you just need to check, is it working or not? Is there any troubleshoot for it or not? Again, baby now delivered, we will make initial assessment and ask the 3 questions. Okay, is it turn, tone, and breathing or crying? If the patient, okay, so we will go for routine care. If these patients are vigorous, full term, and everything is okay, babies who require the stimulation just and respond also, we will give him routine care. They can stay with the mother, and the best thing is the skin-to-skin contact, which gives them warmth and empathy and a good social bond. Okay, we may need initial step beside the mother if needed, because it may not need it, and ongoing evaluation. So that is the issue. If TTC, yes, stay with the mother with evaluation. Okay. If the patient, any one of this one, is not working, you must transfer the baby to the, sorry, now we are transferring it to postnatal ward with the mother. The second point, if the patient need resuscitation, so we are going to admit him for post-resuscitation care. Baby have abnormality with the breathing, baby needs oxygen, baby needs frequent assessment, baby have a risk factor. Okay, all this must come to the NICU for admission. Again, please, this is the golden minute. The first minute, we are doing the initials and the ventilation, initial steps and the ventilation. Second minutes, we need to do chest compression. The third minute, we need to do UVC and the medication. Okay. This is the initial step. Okay, the initial step is number one is to provide warm and then dry. And remember that after you drying by a towel, remove the wet linen. Don't leave it over the baby. It is not benefit to keep it cold attached to his body, especially if it is wet. So dry and remove it. Stimulate, how to stimulate the position also, what is the sniffing position for that. Clear secretion is not a must for every baby. If the baby needs, we can do it. Okay, so for the warmer, now we are speaking about the initial steps. If the baby is 32 weeks and above, okay, we'll go to the warmer. Less than 32 weeks, he need to put in a plastic. Even plastic from your chicken, which one from kitchen can be used, okay? But we have also our own. So we put the baby on a warmer and we put him in plastic wrap with a cap also. I mean, I will put a cap over the head. We need to add thermal mattress. Even if we are going to give him oxygen or air, it must be warmed and humidified gas and increase the room temperature. Very important. If you are able, some hospitals are centralized, but if you are able to make the temperature is 26, it is ideal. You can use skin-to-skin contact if can be allowed, baby's situation can allow it, and the portable incubator. For all this, for the preterm less than 2 weeks. Why? To prevent this baby from cold trauma. What cold trauma can cause? It can cause deterioration and acidosis, metabolic acidosis, and like that. Even if you are going to do any procedure, it must be under thermal control. Okay, but avoid also hyperthermia. So we need the temperature to be controlled within the normal limits. So this is number one, provide warmer. Just will then after that, we are going to stimulate. How to stimulate the baby? It is the baby, we must know two things, okay? The first one, the baby may have, if he got apnea, it may be primary apnea or secondary apnea. I mean by primary, it is just occur after birth. So if you stimulate him, he will cry directly. How to stimulate is just rubbing the back or frickling the foot. Baby doesn't need to be slapped on the buttock, doesn't need to be carried from the lower limbs and try to give him slapping. No, it is very harmful and it can cause even hemorrhage and organ destruction. So please, stimulation must be very, very, very simple, okay? If the patient doesn't respond to this simple, no benefit of like media speak before, you can just squeeze him, you can carry him, you can punish him, you can put him in a cold and hot water like that. All this is a media action, and most of this can give a very, very bad results, okay? For the position of the head and the neck, which is very important, is the sniffing position. I mean the sniffing, which is a slightly extended one. Okay, it will help the patient to breathe easily. It is very important. And the last one is the clearing of the airway. We are not doing it now as a routine for every baby. Before we used, if your baby has a lot of secretion or obstruction, you can go, otherwise no need. And we now spoke about the preterm baby who need extra effect to prevent cold trauma. Okay. I'm just telling you about practice that are changed now. And it will also consolidate the conception that medicine is can be changed. Our practice can be changed. Before, if the patient has meconium stent and amniotic fluid and delivered flat, I mean the TTC, so the tone is flat, okay, he is not crying, okay. At that moment, before, if the patient like that, so we have to go for the labor wards. This just before 2000. You must stay as a pediatrician in the labor ward with your suctions, and the obstetric will deliver the head only, and then shout the mother not to push, so the shoulder will not deliver until you suck meconium from the mouth, and then belay for delivery. And it is very stressful time to go as a pediatrician for every time to do suction and wait and like that. Okay, so they make evidence-based study. They found no difference if you did suction or wait until the baby is delivered. There is no difference. So we said, alhamdulillah, less tiring experience. Then they said if the baby delivered, okay, flat also, already delivered now flat, he is not crying like that, okay, go and intubate directly. So routine intubation of not vigorous. And they said now after many study that if you go like we are doing, give him the first minutes for positive pressure ventilation, doesn't need even to use the laryngoscope or to intubate the baby, just to go for the normal one now. So we escaped this one before. Every patient doesn't cry, you go and intubate. No, it is not now as a routine. That's why the changing of our practice can occur very, very rapid. After that, after the initial step, we are going to evaluate, okay, by three things as I told you. So I asked the OMG 4 questions, okay? Then after delivery, I asked myself about the tone, okay, and crying and like that. And after that, this is the permanent 3 question. What about the respiratory effort? What about the heart rate? What about the pulse oximeter? Is it clear? Oxygenation based on the pulse oximeter. And remember, if you need ECG lead, leave the pulse oximeter also together, okay? When I am using the pulse oximeter, if I anticipate resuscitation, if the positive pressure ventilation is administered for more than few breaths, if the baby has cyanosis or supplementary oxygen is needed. So go directly and apply the pulse oximeter. This is the 4 indication. But remember that it is better to apply this pulse oximeter to the right upper arm. Okay, the right hand, which is the pre-ductal one. Okay. After that, speaking about umbilical cord, because we speak about before we are cutting the umbilicus directly. Many study now, after a lot of study, they found that at the time of a birth, a large volume of baby's blood remain in the placenta. This blood may play an important role in the newborn baby transition. The ideal time for clamping is a subject of ongoing research. In preterm newborn, in preterm, he got a lot of benefit from this one. What is the benefit? High blood pressure and blood volume, decrease the chance of needing medication, require few blood transfusion during hospitalization, possible improve survival, and decrease NAC. For the term baby, also delayed cord clamp may improve in early hematological measurement. There may be benefit of neurodevelopmental, but it can increase the risk of increased jaundice, which is simple and can be treated. So even for stable preterm or term baby, the delayed cord clamping are very beneficial. That's why the decision now, if in most vigorous preterm, clamping should be delayed for about 30 to 60 seconds. Don't clamp it directly. And here is a feature how you can just carry the baby and put him on the chest of the mother and give him a chance until the placenta delivered without cutting the cord. In vigorous term, also we will get the benefit. Remember that two things are good. Number one, during the delayed cord clamps, okay, the baby can be warmed by skin to skin with the mother or put in a towel or plastic if more than 32 weeks. Okay, and remember that until the cord is clamped, the baby will also warmed by the blood which is coming to him. So all this will prevent hypothermia. After that, we can evaluate while the baby of the mother. But if the baby is critical, we can make immediate cord clamping at this situation. If the placental circulation is not intact, like placenta abruption like that, or bleeding placenta previa, or bleeding vasa previa, or cold avulsion, all this can be also delayed cord clamping. We are not doing it. There is no more study about multiple gestation. So they are cutting it directly. Other scenario like IUGR, it depends on how you are planning with your team of OMG. But generally, the delayed cord clamping for 30 to 60 seconds is a good practice and advisable, unless there is something you can contradict with it. Okay, is it clear? After the initial steps, okay, evaluate the respiration and the heart rate and the pulse oximeter. Okay, if the heart rate less than 100, so he need, I mean less than 100, but more than 60, so we need positive pressure ventilation. If increased with spontaneous breathing, okay, or like that, we can consider CPAP. So it is just a very simple equation. Now I have the respiration, the heart rate, the pulse oximeter. If the heart rate is less than 100 for apnea or gasping, you go for positive pressure ventilation. If he has no brady, but he has labored respiration, go for CPAP, as our table before. Oxygen is the first drug, and I spoke to you before. We have this table. At the first minute, we accept 60 to 65 and increase 5 every minute. Until 5 minutes, we expect it to be 85. After that, at 10 minutes, we can expect to 85 to 95. So term infant, you must start the resuscitation by 21 and put your pulse oximeter and take decision if you need to increase. Preterm, start by 21 to 30 and also guided by the pulse oximeter. If the baby is breathing but the oxygen saturation is not within the target range, you can give him free flow oxygen administered. You may begin at 30%. It is not allowed to start, especially for preterm, to start by high oxygen more than 60. Only the situation, if you are going to start chest compression, you can increase FiO2 to 100%. This is just samples of how we are monitoring the baby with pulse oximeter. We are putting him on mechanical ventilator. We are putting a central line for him. We are putting ECG leads, all this. And you can see here, this is pulse oximeter, and this is the target oxygen saturation. Again, now, if after delivery we speak, if the baby is vigorous, yes, this TTC. Here, just to remembering you for the suction, because the suctioning, sometimes if you make a deep suction for the newborn baby, he will get bradycardia. And sometimes if it is high, it can cause pneumothorax. That's why just we need to wiping the baby mouth and the nose. Okay, but to use a bulb or searing or suction if there is secretion, okay, or of non-vigorous newborn. And remember, which are very important, if you need to suck, you must suck in before in. I mean, you must make suction of the mouth before the nose. Why? Because if you suck the mouth, if you suck the nose before mouth and the mouth has a viscid secretions, the baby will cry and will put this secretion inside the trachea. So they always advise to do M before N. I mean suction of the mouth before the nose, and make the pressure maximum 100 for neonates. It is maybe up to 400 for adult. So don't do that because high pressure will cause bradycardia and pneumothorax. Okay, the indication for positive pressure ventilation if the patient is apneic or gasping or the heart rate is less than 100, or if you put this one early, you can for oxygen saturation. How much are you using for this pressure? It is only 20 to 50. So I am going to start 20 to 50, and the maximum will be 40. So the starting point is 20 to 25, and the maximum is 40. How many breathing? This is a very important. Just if you need, this is a term like that. So you are using to use the oxygen 21% for full term and up to 30 for the preterm. And you will put your ambu bagging or anesthesia bag, as you can see. And now there is a one like song, which is press 2, 3. Press means the pressure. 2, 3 for expiration. So press for inspiration, 2, 3 for expiration. Please, the expiration must be slightly prolonged than the inspiration. So press 2, 3, press 2, 3, press 2, 3. How many breaths per minute? The normal breathing for the neonate is from 40 to 60. You must know that. So are giving it 60 per minute. Press 2, 3, press 2, 3, press 2, 3, press 2, 3. It is very important and must be coordinated. I did this for 15 to 30 seconds. If the patient responds, okay, it is a good. If not, I will do assessment now for the heart rate. Usually before, we can assess the heart rate through the umbilical cord. If you put 3 fingers around the base of the umbilicus, you can feel the pulse and count the heart rate. By they said now, more accurate to use your stethoscope. Okay, if you did 15 to 30 seconds and the patient doesn't respond well, so you go for ventilation corrective steps, which are known as Mr. Soba. What is Mr. Soba? Mr. Soba is like 3 levels of correction. The first level is MR. M is the mask adjustment. It may be you are not adjusting the mask, because it must be from mid-chin here and cover the nose, not covering the eye, and must be good intact. And reposition of the head, which we spoke before, which is the sniffing position. And give him 5 puffs of BBV. And check what about the heart, what about usually at the time you are putting the baby on cardiac monitor, so you have the screen in front of you telling you all the knowledge, heart rate improving or not, the respiration, and the oxygen saturation. If not respond, so you can do suction of the mouth and the nose, and as I told you, M before N, and try to open the mouth good, so the BBV will work. And give him 5 breaths. If no response, you will increase the pressure. Now we started from 20 to 25, we can increase up to 40 for term and 30 for the preterm. If no response, after that, you will go for alternative airway. What is the alternative airway? Is it either ET tube or laryngeal mask? Of course, every step you must make sure that the chest is moving and well inflated. So remember this Mr. Soba, which are very, very important in allowing the baby to respond, because the top important for the baby is the ventilation. Tracheal suction, if you are attempting BBV, but baby are not improving, like in case of meconium, you can do, if you find that at the end the trachea is obstructed like meconium, you can intubate. But if you intubate, what is your goal to put this secretion? There is 2 ways, either put catheter and the suction, or you can suck the ET tube itself with a meconium suction device and re-intubate again. There is 2 policy for that. So the high priority of the neonate now is the neonatal ventilation, effective ventilation. So we'll try by BBV. If not response, you are going to Mr. Soba. If not response, you may need to intubate or laryngeal mask before you start chest compression. Okay, if the baby doesn't respond and the heart rate is less than 60, so we are going now to consider chest compression. What is the best way of chest compression? Is the 2 thumbs. Okay, 2 thumbs, because you are supporting the back by your finger and from front is by your thumb. If the heart rate is less than 60 in spite of effective ventilation, it must be coordination with ventilation. I mean, at that point, the ventilation of the baby still continue, and you are going to add on the chest compression. If chest compression both are working and still the baby not respond, so there will be one more who will come to insert UVC and give medication, and all are working. So remember that the ventilator patient, the ventilator staff, is the first one to start and the last one to stop. So now ventilation, if needed, another hand with him, and can you see even the position, how to make the position so it can tolerate the third one. So this one for ventilation, this one for chest compression, and from my side, I may be able to insert UVC, UEC. Okay. How deep I compress? About 1/3 of the chest diameter. So it will be around 4 centimeters in preterm and 5 centimeters in term deep. Okay, how many? It is 90 compression to 30 ventilation. 90, yes, because I told you the heart rate, but the heart rate is 100 up to 180, and the respiration up to 60. So we are trying to adjust and make it as another song. Do you remember the song before? Brace 2, 3, brace 2, 3, brace 2, 3, brace 2, 3, which give 60 breaths per minute. Now I will make it 30 cycle. Every cycle has 4, which is 3 chest compression and 1 breath. So you see now 1 and 2 and 3 and the breath. 1 and 2 and 3 and the breath. 1 and 2 and 3 and the breath. You will do this cycle per minute, okay, which are very important, will give you this rate, 90 compression and 30 ventilation through a 30 cycle. And after how much? Before for respiration, we are assessing after 30 seconds. No, for chest compression, you must continue cardiac massage for 1 minute, for 60 seconds. After 60 seconds, you will ask yourself. But remember that at the time your FiO2 is increased to 100%, and you put the pulse oximeter and the cardiac monitor also to decrease the risk of complication associated with hypoxia. Oxygen concentration should be weaned once as a bigger response. Don't leave it 100 forever, okay? So it is very important. You will increase the FiO2 to 100, but it will adjust again. And here I need to tell you many important points. We are putting our chest compression in the imaginary line between the two nipples, which is the fourth costal space, above the ziph sternum by 1 centimeter at least. It is very important to press on the bone, on the sternal bone, not on the ribs. Ribs you can make fracture ribs. So you put it in the bone and support from behind, and don't. If you press on the rib, you can cause fracture rib. If you press in the abdomen or in the ziph sternum, it can cause trauma either to liver or spleen. So it can cause rupture of them. So take care, please. Inshallah, on the practical session, we will practice that. If the patient doesn't respond, so we are going to consider UVC under complete aseptic technique. Once compression are started, it is advisable to go and start to insert this. So now we are maintaining ventilation, we are maintaining chest compression, we are inserting UVC. If you cannot, you can insert now using the intraosseous needle. A very simple, I will let you see its photo, inshallah. What medication can I give? It is epinephrine, okay? After 30 seconds of ventilation and 60 seconds of chest compression, if still you may need to start the ET tube. If you didn't put the line, you will just a step dose of ET tube and the epinephrine, but the UVC is the best method, okay? May give dose, even if you give through the ET tube, you will repeat it directly after insertion of the line. Details about adrenaline or epinephrine, it must be given very rapid, short. Concentration is 1/10,000. Take care, because many areas have concentration 1/1000 for adult. No, we are using concentration 1/10,000. If ET tube, okay, we are giving it to give him 1 ml per kilo. Okay. If IV, we are giving 0.2 ml per kilo. Any adrenaline given, it must be given with a 3 ml flush through the vessel of normal saline. Also, it will be rapid. Why? Because adrenaline, if stay in the tubes, it will not be effective. So I will give adrenaline very rapid and push 3 ml. I have 3-way now. I just change and push the 3-way. So all adrenaline will go directly to the heart. We can repeat it every 3 to 5 minutes. Epinephrine can be given again immediately in the UVC after inserting, after giving through the ET tube. So it is very important to know that. If no response, we are going to give volume expander. What is the preferred one? We have either isotonic saline or O-negative blood. We didn't prepare ringers like that. Okay, how much is the bolus? It is only 10 ml per kilo. It is not 20 like adult and the children. Before we are using sodium carbonate, and they said there is no sufficient evidence to use it. So no need. Now, an important question. I make use of time. I am working as a team, and we are going to do assessment, initial assessment. We are going to do initial steps, and then I did positive pressure ventilation. I intubate the patient. I did chest compression. I give the adrenaline and normal saline, and I ruled out some cases, some special cases like surgical or pneumothorax or like that. And still at the 20 minutes, I cannot get heart rate at all. So they said it is a strong predictor of mortality and morbidity after 20 minutes. So previous editions, they are taking it after 15 minutes, but now they said you can continue resuscitation, not 10, go for 20 minutes, okay? Continue resuscitation effort, because they said now we have many cases which can survive, and at the same time, we have now the head cooling. If the patient experiences some hypoxia, still head cooling can work him and allow the resuscitation team also to finish their jobs. Okay, between continuing and the long run, you must discuss. At that moment, this is the best and the tiring one that you are going to leave or experiment and leave the baby and go to the mother and tell her, sorry, your baby doesn't respond to all resuscitation, which is now like collapse or shutdown of the hope for the mother. So you must be very cautious, please, because most of the lady, they are susceptible for berberial psychosis. This is the laryngoscope, which looks like a pen, and use it as a pen and just introduce through the mouth by your finger like this. If you cannot intubate or the patient has some anomalies, it is simple. It can be given. We have size 1 for preterm and size 1 for term, like that. And you can give positive pressure filtration through it. But the issue is still lagging, like to give surfactant or like that through it. It still need to be studied. What is the name? Laryngeal mask. These pictures are very important. It will let you see how we can insert intraosseous. Intraosseous, you are choosing the tibia, which is away from the growing blade. Okay, very important, and define it and sterilize. Now it is in every unit we are offered as Chanure, drill. Okay, the needle is inside, so you are using this drill, and now the needle is inside, and you can collect blood and you can give him fluid until you are able to secure another line. So, because the time factor are very, very, very tight, so don't be hesitated until the baby lost his chance of life. If you cannot, go and put intraosseous line. This one is, it is just a recommendation. What is the difference, okay, between this one and the previous one, okay? So the new NRB, which is the 8th edition, speak about improvement, quality improvement program, which are very important. And they are stressing upon the skills of positive pressure ventilation, and change the 4 pre-birth questions now to be gestational age, clear amniotic fluid, additional risk factor, and umbilical cord management plan. The initial steps contain warm, dry, stimulate, position, and suction if needed. Okay, when an alternative airway became necessary, which is the end of Mr. Soba, okay, it is better to put ET tube. Okay, the initial intravenous or intraosseous dose of epinephrine increase now to 0.00, before it was 0.1, which equal to 0.2 ml per kilo. The endotracheal dose is 1. Before it was half of this, so they recommend doubling the dose now. And it must be flush with normal saline 3 ml, whatever the weight. They are advising for skin-to-skin contact for bonding and normal thermia. If the confirmed absence of a heart rate after all appropriate steps performed, consider cessation of a resuscitation effort around 20 minutes after birth, but you must initiate discussion with the senior colleague and with the family. This is unchanged which we speak about. Okay, this is the same like before. This one of my publication about the NRB. Thank you. And this is just the tables about quality improvement. How we are making, I think most of you know this SMART score, which is specific, measurable, achievable, realistic, timely, and how can we apply it for our unit. Thank you for your attendance and hoping the best for you. I spoke a lot and now it's your turn to speak to me.
Doctor,
Yes.
I have a question for the Mr. Sofa part.
Sorry?
Yang Mr. Sofa tadi.
Yes.
Because in the table, after A, which is after the alternative airway, there is written try PPV and assess chest movement. So meaning after we have tried Mr. Sofa, then we try again PPV, or we directly need to continue with the chest compression.
Your voice is not so clear. Can you repeat, please, and increase the volume of your...
Yes, sure, Doctor. In slide 30.
Okay.
In the table, the last row is written try PPV and assess chest movement.
Yes.
So is it meaning that after we have tried Mr. Sofa steps, we will return to do PPV again, or we have to move to the next step, which is the chest compression?
Mr. Suba is a 3-step, as I told you by this table. Okay, we have MR and then give 5 breaths, and that time the baby is already connected to the cardiac monitor and it will tell you no improvement, go for SO. No improvement, so you will increase the pressure and go for alternative, which is intubation. After intubation, you need to give 30 seconds of effective ventilation before starting chest compression. Am I clear? After intubation, you need to give around 30 seconds with effective ventilation before starting before starting chest compression, because chest compression without ventilation will not give any benefit. Is it clear for you?
Doctor, what I understand, even before we do the corrective step by Mr. Sofa, we have initiate PPV at the baby.
Yeah, this is initial BBV, but the baby doesn't respond. So this 115 buff, it may take about 15 seconds or 20 seconds for this known as ventilation corrective steps. At the end of this one, it will end by intubation or laryngeal mask. At this moment, you need to check to give 30 seconds of effective respiration, okay? If it's still low, you can go for chest compression, because most of the patients in neonate, they are not cardiac one. The issue is if the patient has cardiac, you can go for cardiac compression directly. But if the patient is respiratory, no benefit for the heart if you didn't manage the respiration. That's why once we start BBV, it is extra 5% will respond like that.
Okay, Doctor, thank you.
Okay. Any other question? So what will be the plan for your clinical session?
Uh,
Hmm. What is the plan for our clinical session?
because some of us are still in self-isolation. So tomorrow we have swab test.
Tomorrow we have what?
Swab test.
Oh, tomorrow we have swab. Okay, inshallah we will
But Dr. Said want to conduct it online tomorrow morning.
conduct it online.
Online.
Did you feel that it will be give you a good impression or not? I will see today. We will sit together and we will update you tomorrow. Okay?
Okay, doctor.
Okay. Thank you.
Okay.
And keep safety, inshallah, and see you soon.
Okay, thank you, Doctor.
You are welcome. Assalamu alaikum wa rahmatullah.
Thank you, Doctor. Thank you, Doctor.
Doctor.
Assalamu alaikum wa rahmatullah.